Good afternoon, everyone. I am Dr. Nisha Parveen, and I am Assistant Professor in the Department of Chest and TB, ANIMS. And today's session is about approach to chest X-rays. Today, I'll help you to understand how to approach chest X-rays in your day-to-day practice, especially in diseases like tuberculosis. Okay. So most of the chest X-rays that you will see or we see in our day-to-day practice, daily OPDs or wards, most of them will be normal. But it is important that you have to know how to interpret that it is a normal chest X-ray. Only then you will be able to recognize the abnormalities present in an X-ray. Only then you can know whether this is a normal X-ray or this is an abnormal X-ray. So we'll go first towards how to approach a normal chest X-ray. Okay, so the approach towards an X-ray should be systematic. It cannot be haphazard. Like most of the times in our practice, I get X-rays on phones from other departments saying interpret this X-ray, interpret that X-ray, or a patient walks in because some other doctor has sent him or her with an X-ray and he just wants me to interpret the X-ray. But that is not how it goes. It should be systematic. You always have to start. You just cannot take that X-ray and start interpretation. Okay, you always have to start with the history, then you have to examine the patient, get the clinical findings, and only then you pick up the X-ray and you start interpreting it. And whatever findings that you have got, try to correlate with what you see on X-ray. That is the normal and the correct way to do it. Not like take an X-ray and just say this is that, this is this. You will always miss some important findings on the X-ray if you go that way. Okay, and wherever you are in doubt, if there is, you have to ask the patient whether there is a previous chest X-ray which has been taken recent times or some other time that is available, so that you can compare it with that X-ray if you have any doubt. Most of us do not take that pain to ask the patient whether there was an X-ray done before whenever we are in doubt. Okay, so always ask. The patient might be having some X-ray which was taken 2 years back or 6 months back. So you can assess for change. You can see whether this what was the X-ray then and how it looks now. So that will also help you towards diagnosing. So before we start, we have to know what we see on X-ray. Why do we see it? So this is because of the relative densities. Because whatever we see on X-ray, whatever the structures present on an X-ray, all have different densities. Okay, so some will appear least dense, like black, and some on the X-rays will appear more dense, like white in color, like bones. So like gas, if there is air in the lungs, so that will be least dense. Okay, so it will appear black. So that's why lungs mostly appear black. Then the soft tissues, that is because of the fat. Okay, that appears a little bit white. Then water, if there is effusion, if you have seen an X-ray with effusion, you will always see that the density of the effusion correlates with the density of the heart or the mediastinal structures. Okay, then bone, which is the most dense tissue. But sometimes there may be some other foreign bodies present. Suppose if a patient is having a central line inserted or if there is a valve inserted, okay, that those metal foreign objects that will be the most dense, that will appear even whiter than the bone. Okay. Okay, so before you pick an X-ray and start interpreting it, what is the first thing to do? Always you have to look for the patient identification details. Make sure that the chest X-ray belongs to the patient himself. Sometimes we get an X-ray of a male while the patient is a female. Okay, sometimes you get an X-ray which is not at all of that patient. Okay, so you have to first check the patient details, whether that X-ray belongs to that same patient or not. Okay, the next thing that you see is what is the view on the X-ray. So basically, you know the most common views that we use in our daily practice. That's PA view, that is posterior. We will see that later. PA, AP, lateral. Okay, and whether the film was taken with during inspiration or during expiration. Then you have to assess the penetration and exposure, whether it is underexposed, overexposed, or correctly exposed. Okay, and the rotation. So we'll go one by one. So we know there are four major views such as chest radiograph. Mostly we use the first three, but sometimes the fourth one is also used. I'll tell you where you can use it. Okay, and beside these four views, there are so many other views. Like the most common views that you see is posterior anterior or PA view. And then there is lateral view, then there is anteroposterior view, and there is lateral decubitus view. These are the four major views that each and everyone must know how to interpret and when to use it. Apart from that, apart from these views, there are oblique views. Okay, there are lordotic views and apical views, which are not so commonly used that we do not need to deal so much in detail with. So the first is postero-anterior view or the PA position. Okay, this is standard position for obtaining a routine adult chest radiograph. So here what happens? The patient is standing upright. Okay, and there is the X-ray cassette, and the X-ray cassette is the patient's anterior wall of the chest is facing against the X-ray cassette, while the X-ray beam is directed towards the patient from the behind. So what is the position of the patient? The patient stands with the chin. The chin is on the top of the X-ray cassette. Okay, and what about his hands? The hands are placed on the hips. Okay, and the shoulders are rotated outwards so that it should not block the view of the chest. Okay, shoulders are rotated, ensuring that the scapula do not obscure a portion of the lung fields. Okay, and in PA view, we most of the PA views always take the PA view in full inspiration. Okay, but here sometimes we also get expiratory films. The patient must be asked to hold his breath at the end of inspiration. That is at total lung capacity. You have to ask the patient to hold his breath. Only then you will be able to visualize each and every structure clearly. Okay, so this is a PA view of chest X-ray, and this is the position of the patient. Okay, you see, can you see the scapula here? No, because the shoulders are rotated, the scapula is out of the view. The next is the AP view. Okay, this is used when the patient is debilitated or we cannot mobilize the patient or he is unable to cooperate, like mostly in infants. Okay, because the patient is uncooperative, so we cannot ask them to stand in a PA position. So for the AP view, there are two views. You can take it in erect position or you can take it with the patient in supine position. See, this is the erect position. Here, the back of the chest is placed against the X-ray cassette. In the PA view, the front of the chest is placed against the X-ray cassette. Here, the back of the chest is placed against the X-ray cassette, and the hands are on the hip, but the shoulders are not that much rotated. You cannot make the scapula go out of the view in this view. That is the main disadvantage. And this is the supine position. Okay, the X-ray cassette is here. The beam comes from here. Okay, so because there is a distance between the heart and the X-ray cassette, so here in this view, the heart will appear magnified compared to a PA view. So these are two X-rays. Okay, and this is the PA view and this is the AP view. See, can you see the scapula here? No, but the scapula here is very well visualized in an AP view because the shoulders are not rotated, so we are able to see the scapula. What about the clavicles? What do you see the clavicles? The clavicles are right over the lung field, but here you see the clavicles are projected like towards the apex of the lungs. Can you see? Okay, so the clavicles are projected towards the apex of the lungs. Okay, and what about the heart? Here you see the heart appears a little bit more magnified compared to here. So do not, in an AP view, do not straight away go and diagnose cardiomegaly. First of all, see the view, what view it is, and only then you have to interpret the X-ray. That is why knowing the view is equally and very important when you are going to interpret a chest X-ray. So next is the lateral position. In this lateral position, the patient is standing lateral side. Okay, on the lateral, this is the X-ray cassette and the patient is standing on the lateral side. It may be left or it may be right depending on what view you want. And the hands are raised over the shoulders so that they do not obscure the view. Okay, so you get a film like this. So where it is used now? Mostly it is not used alone. It is used in conjunction with the PA view. When you want to see the mediastinum properly, the hidden areas of the lung that we call the epiphysis, Okay, the mediastinum, the dome of the diaphragm, the costophrening angles, the cardiophrenic angles. If you want to see these hidden areas of the lung clearly, if you doubt there is something sitting on it, then you can get this lateral view in conjunction with a PA view that you have already ordered for. And next is the lateral decubitus view. Here also the patient will lie supine. Okay, and how it is labeled, if suppose if you have, if the left side of the patient is placed against the x-ray cassette, then that will be called a left lateral decubitus view. Suppose if there is if the right side of the patient's chest is placed against the x-ray cassette, then it will be called a right lateral decubitus view. So when can you use this view? This view is almost obsolete now, but still we can use it in resource limited settings. Okay, when in cases of pleural effusion, suppose in peripheral areas, you are suspecting the patient, maybe a patient is coming to you with a chest pain, okay, and you're suspecting an effusion, but the effusion is not visible on x-rays because there is no CP angle blunting. Okay, but you're getting your signs of effusion present. What are the signs? Like decreased breath sounds you're getting, maybe you're getting VR decrease. So you're suspecting something is there, maybe an effusion. So you can use this view, lateral decubitus view. In that, suppose if 50 to 100 ml of fluid is there in the CP angle, that will layer over here. Okay, usually 100 to 200 ml of fluid or 200 to 300 ml fluid must be present for CP angle to be blunt. Okay, and suppose if it is not there and still you are suspecting, you are having strong evidence of effusion in your clinical examination, then you can order this view. When you do not have an ultrasound or a CT, you can order this view. So the fluid will come out of the CP angles and it will start layering here like this. Okay. So for the quality of a radiograph, there are three main things. First is inspiration view. Whether the view was taken in inspiration or expiration, it must be an inspiration. There are scenarios where expiratory film is of importance, but most of the time, for a good quality radiograph, we want the film to be taken at total lung capacity or full inspiration. Okay, then the penetration or the exposure, and then rotation. So inspiration. So the chest X-ray should be obtained with in full inspiration. Only then you can see all the structures clearly. So how do you know whether a chest X-ray is taken in inspiration or not? So you go for this. Okay. So these are the two X-rays of the same patient. So one was taken in inspiration and the other was taken in expiration. Oh, no, this was not. Okay, so these are the ribs. Okay, these are the anterior ribs and these are the posterior ribs. Okay, so the anterior ribs in a PA view will be less distinct. Okay, so you have to count the anterior ribs or you may go for the posterior ribs. So the anterior ribs the dome of the diaphragm should cut the anterior ribs at the 5th or 6th rib. So you can count like 1, 2, 3, 4, 5, and 6. So this view is taken in inspiration. Okay. And here, this is the first rib. 1, 2, 3, 4. So the dome of the diaphragm of the right hemidiaphragm is cutting it at the 4th position. So this is an expiratory view. So see the difference. Here you can see a major portion of the lungs. Okay. And here the heart is also it appears to be magnified. So most of the time when I get a X-ray which was taken in expiration, most of the time the findings written are cardiomegaly or increased bronchovascular markings, but it is not so. First you have to see whether at what what breath was it taken, whether it was inspiration or it was expiration. Similarly, if you go for the posterior ribs, the posterior rib should be cut at the 8th or 10th rib. Okay. Next is penetration. So if if an X-ray film is properly exposed, you should be just able to see the lower thoracic vertebra, not very clearly and not completely opaque. Just it should be just visible. Apart from that, what else should be visible? The trachea, aortic arch, pulmonary arteries, etc. The bronchovascular structures that should also be visible. Okay, so what about the exposure of this X-ray? Can you see the lower thoracic vertebra here? No. What about the heart? The heart is completely opacified. It is appearing much whiter. Okay, and what about the lungs? Okay, can you see the markings very clearly? The lungs are appearing more dense. Okay, it is much dense and whiter. So in this kind of, you cannot visualize the mediastinum properly, and what it will give the appearance of infiltrate, so pseudo infiltrate. So you may interpret it wrong. So you should be able to just see the thoracic vertebra here, which is not at all seen here. Okay, so this is an underexposed film. And what about here? It is so clearly visible. All the thoracic vertebrae are very clearly visible. And what about the heart? The heart is appearing more radiolucent and the lungs are appearing much darker, just like patients of emphysema. Okay, so this is an overexposed film. You cannot read anything on the lung fields. Okay, and what are you going to miss? You're going to miss so many findings, especially findings of pneumothorax. Okay, this is appearing very dark. So this is an overexposed X-ray. So if you get an X-ray which is underexposed or overexposed, do not interpret. Ask the technician to repeat the X-ray. And next is rotation. So what about the rotation? Rotation is like the centering, whether an X-ray is well centered or not. So for that, you have to see the spinous process of the thoracic vertebrae. Okay, you draw a line in the middle and you see the clavicular head of right and left clavicular head. They should be equidistant from the line that you have drawn along the spinous process. But here, what is happening? The line is not equidistant. It is farther away in the right and it is less equidistant, it is closer in the left. So this is a rotated film. So what will happen in a rotated film? One side may appear darker and the other side may appear whiter. So again, you are going to miss findings. Okay, or you may think that there is a consolidation on the other lung, or you may think that there is a pneumo on the other lung. So all these confusions can happen. So whenever you're getting an X-ray, you have to look for the rotation, whether the X-ray film is well centered or not, by drawing a line along the spinous process of the thoracic vertebrae and seeing whether it is equidistant from both the right and left clavicular heads. Then we have something known as the ABCDEFGHI approach for interpreting X-rays further. Okay, so A stands for airway, B for bones and soft tissue, C for cardia, D for diaphragm, E for effusions, F for fields of lung, G for gastric bubble, H for hyla and mediastinum, I, there is also instrumentation that you should not forget, and then only you give an impression. So first we'll look for airways. So in a normal chest X-ray, so you can see the trachea. Okay, in airways you must be able to see the trachea properly.
गुड आफ्टरनून मैम, बहुत दिन बाद आपका आवाज सुना ही नहीं देता ना, और चेहरा तो भूल ही गए ना, बात उधर नहीं है, बात
So this is the right main bronchus, this is the left main bronchus. Sometimes you will also be able to see the right upper lobar bronchus, and this is the carina, the division of the right main bronchus and the left main bronchus. So these are the major things to see on an airway. Always give importance to carina, because sometimes you can miss out findings here. The carina is mostly acute. Okay, almost always less than 90 degree. Okay, so whenever there is playing of the carina, or there is, if there is an increase in the angle of carina, means there is something sitting there. Like most commonly, it is a subcarinal lymph node. So always carina should also be given importance when you're assessing airways. And next are the bones. So in bones, mainly I told you about how to like count the anterior ribs and count the posterior ribs that you can see. Apart from that, you also have to give importance to the other bones like clavicle, scapula. Sometimes there may be a fracture. Do not miss out rib fractures, and always the spine. For what you have to see, you should not miss a case of kyphosis or a scoliosis. Okay, so that is why bones should also be given equal importance as that of the other structures present in the chest X-ray. Then next is the soft tissue. So most of the times I get X-rays in obese patients, especially females, obese females who have who are dense fatty tissues of breast, saying ki there is bilateral consolidation, or ma'am there is bilateral effusion. No, why don't you assess the patient first? Always, that is why I always tell you, clinically examine the patient first. If you are having bilateral consolidation or bilateral effusion, you will definitely get findings in the lungs. Okay, just do not send an X-ray saying कि ma'am there is bilateral consolidation, I feel there is bilateral effusion, when you're not correlating with your own clinical findings. What or the only step you have to do is just auscultate the patient, make sure that it is apart from breast tissue, it is nothing else. Okay, so if you clinically examine the patient, most of these X-rays you can interpret yourself. Okay, so you're seeing here the breast shadows. Okay, and here okay, and here there is breast shadow on the right, but the breast shadow on the left is not there. So this is a case of left mastectomy. Okay. And also sometimes you will get patients in ICU, trauma patients or patients who are having traumatic pneumothorax or pneumomediastinum. See the soft tissue, the whiteness of the soft tissue as it appears here is gone. Now it is also appearing black. Okay, so what is there? There is also air in the soft tissue. So this is a case of subcutaneous emphysema. And what about this X-ray? There is gas under the diaphragm. Okay, so all this soft tissue should be also given equally importance, especially in female patients or in obese patients, where this fat tissue can obscure mainly the CP angles and the lower basal zones of the lungs, and you may misinterpret it for effusion or consolidation. And next you have to look at the heart. So heart, first the position of the heart, whether it is levocardia or dextrocardia. Okay, then you will assess the size of the heart. So we know that 2/3 of the heart should be on the 2/3 of the heart should be on the left side and 1/3 on the right side. Okay, and the cardiothoracic ratio should, if it is more than 50%, it is cardiomegaly. It should be less than 50%. But in children, it can go up to 60%. Even 60% in children is normal. Okay, and then look at the other structures. So this is the right paratracheal stripe. Okay, then this is the superior vena cava. Here you can see the azygous arch. You can see the azygous arch. Okay, and this is the right atrium, and here somewhere is the inferior vena cava. So this is the boundary tracing of the right heart border. And what about the left heart border? It will start with the left paratracheal stripe. Okay, then you will get the aortic arch. Okay, and this is the left pulmonary artery. Here between the aortic knuckle and the left pulmonary artery, can you see this concavity? This is the AP window. Okay, as you interpret X-rays more, you will be able to delineate it properly. Okay, this concavity is the AP window. This should also be given a lot of importance, because if something is sitting there, it will become convex. Okay, especially a mediastinal mass. Okay, and then this is the auricle of the left atrium and then the left ventricle. Okay, so this forms the left heart border. Then the diaphragm. So both domes of the diaphragm should be very well, it should be visible. And for assessing diaphragm, as I've already told you, that the domes of the diaphragm can be assessed well in a lateral chest X-ray. So if you want to assess the domes of the diaphragm, you might as well get a lateral chest X-ray along with a PAB. Okay, and what about the left? This is the right hemidiaphragm and this is the left hemidiaphragm. So the right hemidiaphragm is usually 1.5 to 2.5 centimeter higher, as we have already read, because of the presence of the liver. But now the finding is like the left hemidiaphragm is 1.5 to 2.5 centimeter lower because of the presence heart. It is not the liver that pushes the diaphragm upwards, but it is the heart which, because it lies more, two-thirds of the heart is lying on the left side, it pushes the left hemidiaphragm downwards. This is the this is how they teach you in AIMS. Okay. And then you come to the lung fields. So never say there is an opacity in the upper lobe or there is an opacity in the right middle lobe. Never use lobes on chest X-ray. There are only few scenarios where you can use lobes, but mostly in when you come to interpret X-rays, you have to always use zones. You have to divide the X-rays in upper zone, middle zone, lower zones. Okay, so for the upper zone, the first two ribs, you can take anterior ribs. I'm talking about anterior first two ribs. You can take as the upper zone. Then second to fourth rib you can take as the middle zone, and anything below that you can take as the lower zone. So you, any opacity or any infiltrate that you get, you have to interpret it terms of upper zone, middle zone, and lower zones, bilateral, both the sides. So this is the hilum. And the hilum, as you know, it is mainly made of the bronchi, pulmonary artery, and veins. Okay, so what do you look in hilum? Most of the time, hilum will be at the same level. Okay, but sometimes the left hilum can be at a higher position than the right hilum, which is also normal. Okay, it need not be at the same level as in this X-ray. So what do you look for in hilum? You look for the concavity on hilum. Most of them have doubts regarding whether there is some hilar nodes or mediastinal nodes present. So you have to see this concavity. Okay, so this concavity, you have to imagine the concavity. And when there is loss of this concavity, then you have to suspect there is something, some node or a mass sitting at the hilum. Okay, so the mediastinum is very, like the domes of the diaphragm, the mediastinum can be very well assessed in the lateral chest X-ray. Okay, so this is the anterior mediastinum. Okay, this is the middle mediastinum and this is the posterior mediastinum. So if you are suspecting a mediastinal mass or something or a hilar node, as I've told you in the previous X-ray, you can always get a lateral chest X-ray done and confirm it. Okay, the hilar nodes will be visible here. If there is something sitting in the anterior compartment, it will be visible here. Posterior compartment will be visible here. Okay, apart from that, I've already told you the aortic knob, the descending aorta, ascending aorta. All these are and the right heart borders. All this form the right and left heart borders from the mediastinum. So moving on to disease of tuberculosis. Okay, so I have divided the topic into primary, like findings on an X-ray in primary tuberculosis and findings on an X-ray in post-primary tuberculosis and reactivation or secondary tuberculosis. Okay, so primary tuberculosis, we know that it is a novel infection. First time you get an infection and you manifest the disease. Most commonly it is seen in children. So in children, the primary pattern in primary tuberculosis is mostly of hilar lymph node enlargement. Can you see the loss of the concavity? See the concavity here, it is there, but what happens, what is happening to the concavity here? There is loss of that concavity. Okay, so that means there is a right hilar lymphadenopathy which is present. It is one of the most common findings that you see in children in primary tuberculosis. Okay, next we come to you all have heard gone focus. So gone focus will be mostly seen in the middle or lower zones in children, which will be subpleural opacity. So can you see this opacity? I don't know how many of you can make out, but this is a rounded opacity present here. If you have taken the CT, see this is subpleural opacity which is visible here. Okay, can you see this opacity, white in color, a rounded shadow? So that is the bone focus. It is nothing but an area of consolidation and it is usually seen in the mid and lower lung zones. And next is the Ghones complex. So in Ghones complex, again you have a consolidation. The consolidation gone focus, that is the area of consolidation, but this time it is draining from there to a regional node and most commonly it is the hilar node. So these are the hilar nodes. So this both of these form gone complex. Okay. So based on this X-ray, so you have the gone focus, which will be like an opacity or like a tuberculoma, and then when you have the hilar node or a paratracheal lymph node, that's mediastinal or hilar node, then it becomes the gone complex. Okay, and when it gets calcified, that is nothing but the Ranke complex. Because it is calcified, it will be much whiter, and you will be able to delineate it properly. Okay, it will be easy to recognize it on an X-ray when it gets calcified. So in children, it can also present like a consolidation. Okay, a white opacity mostly in the lower lung zones. So primary tuberculosis not only presents like gone focus, it is not necessary that it only presents at gone like gone focus or gone complex or just like hilar lymphadenopathy or mediastinal lymphadenopathy. It may also present as a consolidation, and that is most commonly seen in children who are immunocompromised. Can you make out the air bronchogram to call this a consolidation? Okay. So this is another. So here the consolidation is on the upper zones. Okay. In the upper zone, and this is the hilar enlargement associated with it. See the concavity and see the hilum. Now something is sitting there for definite. Okay. Then you can also get it like a tuberculoma, an isolated opacity. Okay, it will be round. This will be smooth. It's not like other opacities. No, that you get that how we have seen in Gone Focus. This that was not so round and smoothly circumscribed. This is so round and smoothly circumscribed. Okay, and you can see much density in the center. This is the calcification. Okay, and this can be seen in both primary as well as secondary tuberculosis. Okay. Then most common you have seen like pleural effusion and TB, very common here. So how do you differentiate this from a consolidation is most of the time the discussion. Okay, so what about the CP angle here is clear. What about the CP angle here? See, it is clear. What about the CP angle here? It is blunt because it is fluid. It will always gravitate. So the first thing that will be filled if there is a fluid is the CP angle. So first thing, if you want to know whether this is a consolidation or an effusion, you have to look for signs of CP angle blunting. Okay, if the CP angle is blunt, yes. Yes, so there is more chance that this is an effusion. Second finding, in a consolidation, the hilar markings, the vessel markings will be visible. But can you see that markings here? You cannot see the hilar. See, you can trace it up to here. Can you see it here? No, it has been obscured. Okay, so the fluid will always, the effusion will always hide those blood vessels and hilar markings. Okay, you can never be able to trace it further. Okay, but in consolidation, it's not like that. You can trace the bronchi, you can trace the blood vessels also because it is little bit less dense. And what about this sign? This is the classical meniscus sign of an effusion. So if you have this crescent shaped sign, okay, you can say that this is definitely an effusion. Okay, so and apart from that, what else will help you? Obviously, your clinical findings, your clinical examination of dullness on percussion, VR is decreased breath sound. So all this will also help you towards aiding your diagnosis as effusion. Okay. So what about this X-ray? This X-ray, most of the people will comment it is a completely normal X-ray. Okay, but I say this is not a normal X-ray. There is an effusion hidden here. So first you go for the CP angles. Okay, so CP angles are clear. Okay, it is not obliterated. Okay, but what is the difference here? You see the dome of the diaphragm. The concavity, the convexity, it is towards, see how smoothly it has come. Okay, and almost the convexity is in the mid-scapular line, you can say. But what about here? Okay, the convexity is pushed a little bit lateral side. Okay, and what about it is almost and the right hemidiaphragm is slightly more elevated. Okay, so this when you see that the convexity is pushed more towards the lateral side, okay, and the right hemidiaphragm is or the left hemidiaphragm is slightly more elevated, then you always suspect that there is some effusion sitting over there. Okay, so it will be mostly a subpulmonic effusion. Okay, you can take a lateral decubitus view to confirm it, and if you ultrasound or CT is available, then you can go ahead with it. Okay, so always try not to miss the subpulmonic effusions. Okay. Then loculateral pleural effusion. So again, the first thing in loculateral pleural effusion, first thing always see for the CP angles, because only if there is a large effusion you will get other findings. In small effusions you may not get so. So in TB what happens when there is an effusion, if the patient is not on treatment or has not been diagnosed, or if the effusion is a long standing one, the effusions in TB it tends to get organized. Okay, and it becomes loculated. So here the CP angle is obliterated. Okay, you can see the meniscus sign very clearly here. Okay, but what is this? Now we are confused whether this is a consolidation, okay, whether this is some other opacity, or whether this is also an effusion. So what I say is, look from where the effusion is arising. Okay, it is almost arising from the pleura. Okay, and it is organized in such, it is having such a smooth and well defined outline. Okay, so it is definitely, and it's arising from the pleura. Okay, and the pleura and the CP angle is obliterated. So definitely this is an organized effusion or a loculated pleural effusion. Okay, again you can aid it through your clinical examination findings. So that is why it is very important that you also assess the patient clinically. Now again here there is an opacity. Okay, the very well defined, appearing smooth like a cyst, almost like a cyst it appears, but this is not a cyst. Okay, what it is, there is an effusion, definitely CP angle is blunt, there is slight meniscus sign present. Now you can see the fissure. Okay, so you can see the minor fissure traveling through through this opacity. Okay, and the fissures are bulging with effusion. Okay, usually you cannot see the appreciate the fissures now, but here you can appreciate the fissures when it is going through and through this opacity. Okay, so this is nothing but an encysted effusion. Okay, sitting inside the minor fissure. So this is also known as phantom tumor. The next is atelectasis or volume loss. Okay, so there is a right upper zone opacity. Now here I have written upper lobe. Why? Because I have clearly this minor fissure has completely clearly delineated it that this is an upper lobe. That is why you can say this is a complete upper lobe, because it is restricted by the minor fissure. Okay, otherwise you have to call it as zones only. Okay, and what are the other findings that you get? What about the trachea? The trachea is slightly pulled towards the right. And what about the minor fissure? The minor fissure is also pulled upwards. Okay, it is neither straight nor bulging, but it is having a concavity. Having a concavity. Okay, so these are the signs of volume loss or atelectasis. Okay. So now we come to post-primary tuberculosis or reactivation tuberculosis. We know it has predilection for upper lobe because of higher oxygen tension and less lymph and blood flow. In post-primary tuberculosis, most of the time you will not see lymphadenopathy, and it has propensity for cavitation. Okay, so the first X-ray that we see, okay, so upper zone predominant, and slight middle zones are also involved. So upper zone predominant, and what do you see? Focal patchy opacities are there. In some areas, they are organizing to form consolidation. Okay, mostly you will see it in the upper lobes and also in the superior segments of lower lobes. This is very typical and characteristic of tuberculosis. Okay, so what do you see? There is a consolidation, but inside the consolidation, what is happening? There is necrotic breakdown, and it is going to form a cavity. Cavity here, cavity here, cavity here. So these are signs of cavitation mostly in the upper zones. Here it is the right upper lobe because you can see the minor fissure. So this is very characteristic of tuberculosis. Similarly here, this is the consolidation, and then here is the cavity formation. Now, fibroproliferative lesions. Here, in these kind of lesions, there will be signs of fibrosis as well as proliferation. So, what do you get? There are signs of fibrosis. Okay, there are so many strands, patchy opacities, and cavities, and few areas you can also see necrotic breakdown, and few areas you can see bronchiectasis shadows. So this is a fibroproliferative lesion. Okay, here all the airways, the lung parenchyma, everything is involved. So it is a fibroproliferative lesion. Then this is tuberculous bronchopneumonia. Okay, so this you can see almost like small nodular opacities. Here there are cavitations. Here also there are cavitations. Here there are bronchiectasis which is taking place. Okay, so what is this? This is bronchopneumonia. It is spread not only in the lung parenchyma, but is also it has spread to the airway. So in endobronchial TB and all, you will get all when it has spread endobronchially, you will get this kind of findings. It is very easy to confuse it with miliary. But why not miliary? Because there are signs of cavitation. It does not look like a pure hematogenous spread. More, it looks like a endobronchial spread. And this is a cavity, but this cavity has got an air fluid level. Okay, so this is a lung abscess. So lung abscess, if you are in foreign countries, you will suspect mostly other bacteria. But in India, the first thing you have to suspect is mycobacterium. Also, it is in the upper zone. So this is a classical picture of miliary tuberculosis. So most of the time in post-primary, the upper zones of the lungs will be involved. Why in miliary, the lower? It is having a basal predominance. Okay, basal predominance. Why? Because it is a hematogenous dissemination. No, so blood flow to the lower areas of the lung is more. So that is why in miliary shadows like 1 to 3 mm dot like millet seed like appearance you will get. And mostly it will be basal predominance. This is a classical picture of miliary tuberculosis. And there are no other signs of cavitation, bronchiectasis, fibrosis, nothing. Just pure millet seed appearance. Then we'll move towards the complication and sequelae. So the first thing is aspergilloma. So this is the cavity, most probably tuberculous in the upper zones of the lung. What do you see inside this cavity? There is another. This is a cavity, and inside the cavity there is another opacity sitting. So this is a pure air crescent sign, and it is seen in aspergilloma because the cavity has been colonized by aspergillus species. Okay, and this can give rise to hemoptysis, severe or life-threatening hemoptysis also sometimes. Okay, so now next is fibrosis, the most common complication or sequelae of tuberculosis. So this is a chest X-ray with fibrosis. Now you can tell me the findings. See, what is the trachea is pulled towards the right, very much gross deviation of trachea is present. Okay, what is happening here? Okay, here there is atelectasis, volume loss, atelectasis. The entire right hemithorax is smaller. You see the left hemithorax, doesn't it appear larger? Compensatory hyperinflation has taken place. Here you see the crowding of the ribs, not much gaps in between the ribs. Okay, and what else? There are fibrotic stands. This is the hemidiaphragm. It is having a tenting. So these are all the signs of fibrosis because the right has gone for fibrosis, the left has had compensatory hyperinflation. And you cannot see any active disease signs here. Can you see any patchy infiltrates or nodules or consolidation? No, you cannot. Okay, so this is a sequel. Again here, okay, here again there is a pull of the trachea towards the lung, towards the left. Okay, mediastinum entirely pulled towards the left. There is decreased thoracic volume on the hemithoracic volume on the left side. Right side has increased. This, see the gastric bubble, it has come up. Usually this should be down. Okay, because the heart is pushing the left hemidiaphragm downwards. But this has, because of the pull, mostly the lower lung lobes have gone for collapse. Okay, that is why this opacity. Okay, so you cannot say this is an effusion because you have all other findings of fibrosis here. Although the CP angle is blunt. Okay, but you cannot say this is effusion. Look for other additional findings. Okay, when you are having gross pull towards the left, when the gastric bubble and hemidiaphragm of the left is shifted upwards. So this cannot be an effusion. This is a collapse. The next is bronchiectasis. So you can see this ring-like shadows, cystic shadows, ring-like shadows completely on the from top to bottom. Okay, all the entire lung is involved of the right side, and it has undergone fibrosis. This is compensatory hyperinflation. Here, which lobes are affected? Mostly you can say the lower lobes and the lingula if you take a CT. And this is a tuberculous empyema. So why am I saying this empyema and not a loculated effusion? Because it looks like a long-standing effusion. Okay, there is rib crowding. Okay, and you see this pleural line. It is appearing much whiter. So it is showing that something long-standing process has taken place and it is very well organized. So this is a tuberculous empyema. If you go for a CT, that white thing that you can see the pleural ring, it will appear as a split pleura sign in CT. And this is characteristic of empyema. So this is a complications of TB I'm talking about. This is a hydropneumothorax. There is. Do you see the meniscus sign present here? The crescent shape? No. Now it has gone for a air fluid level. And what do you see here? This is the collapsed lung border. Okay, see, this appears more black. You cannot trace the blood vessels here in this area. And whenever there is air inside the lung, the meniscus sign will disappear and you will get an air fluid level. So if there is an air fluid level like this, which is covering the entire lung on one side, then you have to suspect there is a hydropneumothorax. So this is a right-sided hydropneumothorax. And what is this? This is a pneumothorax. See, the cavity of the TB ruptures, and I don't know why here we do not get much cases of pneumothorax, but if you go outside, there will be a lot of complications of TB coming as pneumothorax. Okay, so this is the collapsed lung. You can compare both these lungs. This is appearing much black. You cannot trace these vessels beyond this. This is the collapsed lung border, and what you can see here, there is blunting of the right CT angle, and most probably it is due to the reactionary fluid of the pneumothorax. So this is a classical case of right pneumothorax. So in pneumothorax, always trace out the pleural line. What is the pleural line? The collapsed visceral pleura, the collapsed lung border. So can you see this line? Most of the people will confuse it with the scapular border. Okay, do not confuse it with the scapular border. Okay, trace the scapular border and see, and can it be traced downwards? Okay, so the scapula is away, and this is something else. This is the border of the collapsed lung. Okay, and you cannot trace. It is much black. You cannot trace the blood vessels over here. So this is a case of right-sided pneumothorax. And what do you say? Will you call this? See, here also everything is black. Okay, you cannot trace the blood vessel. But is this a case of pneumothorax? No. Why? Because you cannot trace it. This is the scapular border. Okay, do not confuse this border with that of a pneumothorax collapse lung. This is the scapular border. Okay, and why I cannot say this is as pneumothorax? Because there is no collapse lung border. I cannot see the collapse lung border. Okay, so this cannot be a case of pneumothorax. Okay, and apart from that, what is there? There is a pull of the trachea here. So, and there is a lot of cavitation here. So this is nothing but a very big cavity, which is sitting on the left upper zone and middle zone. So this is not a pneumothorax. So you always have to trace for the collapsed lung border in a case of pneumothorax. Plus, what will help you? Your clinical findings. Now, this is a case of tension pneumothorax. So, for apart from the pneumothorax that we have seen earlier, why am I calling it a tension pneumothorax? Because apart from the collapsed lung border, the mediastinum is completely pushed towards the opposite side. Very gross deviation. Okay, the heart is completely pushed. So the pressure inside is very high. So there is a lot of tension inside. Apart from that, what can you see? You can see there is inversion of the right hemidiaphragm. Okay, so that is why it is a case of tension pneumothorax and it's need prompt intervention like ICD or needle aspiration. And next I'm giving you some some chest X-rays where you may confuse it with X-rays of TB. So this is a consolidation. Why do you say this is a consolidation? Can you see the air bronchogram here? Okay, can you see these black lines? And this is the dense opacity. Okay, which is appearing white. So this is nothing but a left upper zone and middle zone consolidation. Okay. Now you can also confuse it with mass. Okay, why am I calling this as mass and not a consolidation? See the density. Okay, this is less dense. And what about it is very white? And what other findings can you get? See, this is it is having irregular border, a very much irregular border, and in some areas you also have speculations. And what else? There are nodular opacities which might be taken for satellite nodules. Okay, so this is a case of a mass because it is much dense. Okay, and it cannot the borders are irregular and with speculations, and there might be some satellite nodule sitting over here. Okay, and it appears to have arisen from the hilum. And this is a case of metastasis. Okay, so there are patchy opacities, but what about the opacities? They are very well defined opacities, not like the patchy opacities that we get in tuberculosis, which are not so well defined. This is like very rounded, well defined, almost smooth looking opacities. So this is nothing but cannonball metastasis. So if you get an X-ray like this, do not also have metastasis as your differentials, just not TB, patchy opacities of tuberculosis. Okay, so now this is not a consolidation. Why? Because there is no air bronchogram. Can you see an air bronchogram? No. And why it is not a mass? Because see the outline. See the outline. So well delineated. It is so smooth appearing. Inside also it is very homogeneous. Okay, this is the main finding. It is so smooth and well defined. So this is nothing but a cyst. And this is a large pleural effusion. It is almost shifting the trachea towards the opposite side. So sometimes in pleural effusion, sometimes in some cases of pleural effusion, you will get a very large effusion like this. But always, when you get a very large effusion like this, never forget about the trachea. Always see whether the trachea is shifted to the opposite side. Why? Because sometimes there can be an effusion present and still the trachea will be center or shifted to the same side. When it is that, when does it happen? When there is any intrabronchial thing sitting in the right side. So at that time, there will be a large effusion, but the trachea will be shifted or not at all shifted. It will be shifted to the same side or it will be not at all shifted. In that cases, you must have carcinoma or some intrabronchial tumor as your diagnosis in your differentials. And so now this is a X-ray of a child. So what do you see here? There is an opacity. Okay, it is not a consolidation, no air bronchogram. So what is this? This is nothing but thymus, sale sign. So many of you confuse it with a consolidation. So never forget that this sign is normal in infant and involute by the age of 2 to 8 years. So the take-home message is whenever you get an X-ray, first I'll say you be systematic. Okay, always take the history, assess the patient clinically, record your findings, and then only take the X-ray in your hands. In that, what will you see first? Patient identification details and the quality of the X-ray, and only then you proceed towards the interpretation of the X-ray based on ABCDFGHI. Okay, always remember it is not a chest X-ray. It's a chest X-ray. It is not a lung X-ray. So just do not focus on lung. Also look for the soft tissues, the bones, the mediastinum, and also the abdominal contents. Okay, and concentrate on the hidden areas. So how can you see the hidden areas well? To see the hidden areas well, you can get a lateral X-ray along with the PA X-ray. Okay, and always ask for compare with old films and lateral films. Okay. Thank you.